Hello and welcome. My name is Stephen Lee. I'm in Elisa Kona-Falken's lab at Columbia University, and today I'll be talking about how focused ultrasound can lower pain perception in a neuropathic pain patient population. Our peripheral nervous system is involved in a majority of our sensory experiences, and this ranges from touch and vibration, as well as all the way to temperature sensations. But the most important sensation that we have is the sense of pain, which is important for our everyday navigation of the world to safely traverse this world. And these sensations start at our sensory receptors at free nerve endings in the skin. They travel all the way to our spinal cord up to the brain for processing. And this is what we consider nociceptive pain signaling, which is normal and healthy pain sensation. Now, in neuropathic pain, this pain is caused by the nervous system itself, either by damage or disease. And neuropathic pain's prevalence is estimated to be between 3 and 17% of the general population, with this number growing each and every day, especially in the United States with the growing opioid epidemic. Current stimulation methods are required for effective treatment. However, they lack either spatial targeting or invasive. Thus, we thought it'd be pertinent to use focused ultrasound to modulate peripheral nerve activity as a non-invasive alternative to the current stimulation methodologies. And we know that focused ultrasound can modulate brain circuits, specific neurons, ion channels, as well as peripheral nerves in mice. In fact, our group has shown in ex vivo we can excite different population of nerve fibers, and we know that we can also apply focused ultrasound to the sciatic nerve in mice to activate compound muscle activations in the tibialis anterior and the gastrocnemius muscle, which are innervated by the sciatic nerve. And so the objective of this study was to understand how we can use focused ultrasound now in humans to alter nociceptive pain first, as well as neuropathic pain in a clinically viable neuropathic pain patient population. The FUS system and stimulation device we're using here is a 1.1 megahertz transducer, 4 elements so that we can steer the beam for added flexibility with a 15 by 1 millimeter focus. And the pulse parameters we're using is a 5 millisecond pulse duration, a single sonication for the healthy, and a 15 Hz PRF train for 10 seconds in the clinical. We use 7 focused ultrasound pulses as well as 7 sham in a randomized fashion in the healthy, and then we up the number to 20 FUS and 20 sham in the clinically relevant population, looking at a 0 to 7.8 megapascal pressure range in healthy and settling on a 4.8 megapascal pressure in the clinical population. We have an interstimulus interval of 3 to 5 minutes in the healthy because we're using a thermal stimulus here, and we have a 10 to 20 second interstimulus interval for the clinical population. And so we have a concentric array, which is 7.8 megahertz 104 element phase array, which fits into the center of our focused ultrasound transducer, as you can see on the right. These are attached to single Verisonic Vantage with a HIFU and extended burst option. And we can use these devices in tandem to be able to identify the nerve and apply displacement imaging to confirm whether we are delivering focused ultrasound to the nerve. And we can use this measurement of displacement to further characterize our changes in pain. And we asked the subject to rate their pain from 0 to 10 on this visual analog scale based on the Wong-Baker Faces Pain Rating Scale. So to understand how focused ultrasound can alter nociceptive pain sensation, we use the sequence denoted above. We use a randomized sequence of 14 trials, 7 FUS and 7 sham, indicated by the highlighted orange and the shaded gray, and each of these trials involves either FUS or sham pulse, coincident with a thermal stimulation for 2 seconds onto the C6 dermatome, which is innervated by the median nerve, as you can see on the diagram on the right. We apply our FUS in our imaging probe to the median nerve proximal to the thermal stimulation area. And we employ 13 healthy subjects, 5 male, 8 females, ages from 20 to 40. And so the subjects are denoted above, sorted by displacement and increasing pressure, and these are the raw pain ratings given for each trial. And we see immediately that there are some patients that experience significantly different pain ratings from FUS pulses to sham. If we group all of them together, we see that FUS decreased pain ratings significantly by 0.28 units. And plotting the changes in ratings over the nerve displacement in this 2D distribution, we can see there are three different populations, ones that have negative change, no change, and positive change. If we group our changes in ratings of all of our subjects by nerve displacement this time, we see there's a significantly different decrease with patients that receive 27 to 67 microns of nerve displacement compared to ones that receive less than 27 microns. And this decrease is 0.86 units. Now again, this is nociceptive pain sensation. And so to understand how focused ultrasound can alter pain sensations in a clinically relevant neuropathic pain population, we decided to use a mechanical stimulation this time instead of a thermal one. We have a randomized sequence again, but this time using 40 trials, 20 FUS to 20 sham, and this time we're also using a FUS train of 10 seconds, and we apply the mechanical stimulation halfway between the stimulus. And so we apply it in a similar fashion to the previous study, as you can see in the diagram on the right, where we're applying focused ultrasound proximal to the mechanical stimulation site. We use 10 neuropathic pain patients, 3 male and 7 female, ages 51 to 74, and in addition to in between FUS and sham pulse controls, we have 6 on-target and 4 off-target controls. And the 10 different neuropathic pain patients we're using had different pathologies on different nerves, stretching from the ulnar nerve to the sciatic nerve, sural nerve, tibial nerve, as well as the common peroneal nerve. We employed 2 nerve biopsies with different symptoms. One had localized pain as well as the other had diffuse pain. We have 1 nerve entrapment patient, 1 nerve compression, and 4 different nerve injury model patients, 1 nerve tumor patient, and a post-amputation neuroma. And the symptoms that the patients exhibited stretched from radiating or throbbing pain to persistent heat, electricity, and paresthesia, as well as persistent pain. But the one inclusion criteria we had for this study was that each and every patient had to have robust and repeatable pain from a mechanical stimulation. And so if we stimulate in the fashion that we denoted before and plot the changes in ratings for each of the patients, we see that there is not much different within patients as we saw before with nociceptive pain. And if we look at the changes in ratings for all the subjects, we don't see any significant decreases in FUS compared to sham. However, we do denote that patients that receive on-target on the left versus patients that receive off-target stimulation, as the focus was placed 4 to 5 centimeters off the nerve, the ones that had on-target stimulation had decreased ratings compared to the off-target, where they either stayed the same or increased by 3.16 units. And again, if we plot a 2D distribution of the ratings as compared to the nerve displacements, we see 2 different groups, ones that receive negative change as well as ones that receive no change at all. And we can cluster the change in the ratings for each of these patients to see a similar trend as before. What's interesting though is that the healthy subject distribution compared to the neuropathic pain patient distribution is very similar. When there's little to no nerve displacement, the pain ratings are given in a normal distribution. There are equal numbers of positive and negative changes in ratings. As we apply more nerve displacement, we can skew these changes in ratings more negatively. We start to see more negative ratings given. As we increase the pressure, there is some sort of saturation. Nonetheless, there is some fundamental similarity between the 2 subjects and how nerve displacement is involved in this process. So to conclude, focused ultrasound decreased pain perception by 0.28 pain ratings compared to sham in healthy human subjects. However, no acute changes were observed in neuropathic pain patients. Instead, on-target stimulation seemed to decrease pain in neuropathic pain patients by 3.16 units compared to off-target shams. And this signals to us that there is a conditioning or some longitudinal long-term effect of focused ultrasound. And for both studies, nerve displacement decreased pain ratings, where the optimal range of displacement was shifted for neuropathic pain patients. And so future work is to adjust the pain rating scheme for inclusion of other metrics such as the McGill Pain Questionnaire, as well as objective measurements such as EEG and SSEPs. And lastly, we would like to investigate longitudinal effects within the same patient population. So I'd like to acknowledge all the people that have advised and helped on this study, as well as our sources of funding. Thank you very much.